Hi everyone, I'm Dr. Valerie Flores. Looks like we still have some people joining, so I'll wait a few minutes. I hope everyone's enjoying their Thursday evening. I think we still have some people joining, so I'll wait a little bit longer. I think a few more people joined. Again, I'm Dr. Flores. I'm just going to wait another minute or so just to give people a little more time to join. I'll give it one more minute. Okay. We'll go ahead and get started. So as I mentioned, I'm Dr. Valerie Flores. I'm one of the fertility specialists here at San Diego Fertility Center. I am originally from Southern California, although I completed most of my training on the East Coast. I went to medical school at Yale, completed my OBGYN residency at Brown University, and then returned to Yale for my fellowship in reproductive endocrinology and infertility, and stayed on as a reproductive scientist and development program scholar. So I was a physician scientist for some time before returning to Southern California to help take care of all my patients here. Today, we're going to be talking about the recurrent pregnancy loss, really understanding the various causes of recurrent pregnancy loss, and also talking about available treatment options. What I wanted to go over today was first just defining what recurrent pregnancy loss is, and then from there reviewing the various causes, looking both at hormonal and metabolic conditions, genetic causes, an autoimmune condition known as antiphospholipid antibody syndrome, anatomic considerations, as well as male-related causes, and then we'll go into treatment options. So how do we define recurrent pregnancy loss? It's defined as 2 or more pregnancy losses, and these can occur at either less than 10 weeks of pregnancy or greater than 10 weeks of pregnancy. You may read about different definitions based off of different organizations who define them a little bit differently. There's another type of pregnancy loss known as a biochemical loss. This is where we see that there is initially a positive pregnancy level hormone, and then ultimately that declines if we're able to actually see a pregnancy inside of the uterus. I will say that for the purposes of the majority of our patients here at San Diego Fertility Center, we treat those as pregnancy losses as well, and so would count that towards the 2 or more losses. And this is a disorder. It does require evaluation and treatment. And the one thing that I would really like to highlight to you, which I also highlight with all of my patients, is that if you struggle with this, there is nothing that you did to cause any of these losses. A lot of times patients will think about a food they did or didn't eat, a medication they did or didn't take, travel they did or didn't do, or exercise they did or didn't do, but none of that actually causes a miscarriage. So there's nothing that you did wrong. Sometimes we do kind of go down this rabbit hole of thinking that there's something that we could have done differently, but there isn't. This is not any space for blame. These can happen. It's just that it is a little bit less common to have more than one pregnancy loss. And so that's why once there's a diagnosis, once we see that there have been 2 losses, we do an evaluation for this. So one of the first things that I wanted to talk about in terms of hormonal causes are thyroid-related problems. I did actually include a little graphic of what's happening with thyroid hormone because I think sometimes it can be a little bit confusing when we talk about hypothyroidism versus hyperthyroidism. So essentially, this is supposed to represent the brain, the hypothalamus. That stimulates a different area of the brain to release TSH. So that's what we're checking actually in the lab, thyroid stimulating hormone. TSH is what stimulates the actual thyroid gland, which is this here, to then make thyroid hormone. So when we say that individuals are hypothyroid, it means that the TSH is elevated because thyroid hormone is low. And thyroid hormone is responsible for metabolism as well as growth and development. And so it is something that we do recommend treating, well, for screening for and then ultimately treating because we also know that it can contribute to miscarriages. It actually can also contribute to irregular cycles. And so that can also make it harder to get pregnant. So it can also contribute to infertility. There's a separate condition called hyperthyroidism. So this is where TSH is actually very low, but the thyroid hormone itself is actually very high. That requires treatment as well. It can also make cycles irregular and so can contribute to both infertility as well as recurrent pregnancy loss. There's a separate condition known as subclinical hypothyroidism, which is where we see that the thyroid hormone is a little bit elevated, or rather TSH is a little bit elevated, but thyroid hormone levels are normal. And for a long time, we used to think that that contributed to miscarriage as well, particularly if patients had an elevated thyroid autoantibody. So these are antibodies that try to attack the thyroid gland. More recently, the data has really undergone a lot of scrutiny, and so at this time, it's really individualized. So when you see your provider for a consultation, we still will check for thyroid hormone, TSH, and also check for thyroid autoantibodies. Depending on what your TSH level is and whether or not you have positive thyroid antibodies, we'll individualize treatment for you to see if medication will help in terms of minimizing the risk of a miscarriage. Another potential hormonal cause is elevated prolactin. So prolactin is another hormone that comes from the brain. However, it does something a little bit different. So when there are high levels of prolactin, it also acts on the pituitary gland, but ultimately actually leads to decreased hormone levels. Sorry, let me go back. leads to decreased hormone levels like estrogen and progesterone. Actually, really, it's decreasing some hormones in the brain called FSH and LH. Those are normally responsible for telling the ovary it's time to make an egg each month. So elevated prolactin essentially can make cycles irregular because of the fact that it's inhibiting FSH and LH, inhibiting the brain from telling the ovary it's time to make an egg. Some of the symptoms, sometimes women can be completely asymptomatic. Other times, patients can actually experience breast discharge. And then, actually, not all patients have irregular cycles. But if the prolactin level is elevated, whether or not the cycles are irregular, we do still note that it contributes to miscarriage. And this is because it really alters the effect of the egg development. So I know I mentioned that normally prolactin can fully inhibit FSH and LH or egg development. Sometimes it's not completely inhibited, but we do see that it affects the ability of the egg to really make estrogen and progesterone, which are important for implantation purposes. So it ultimately affects the ability of the uterus to undergo all the changes it needs to undergo for implantation. We also will routinely check vitamin D and also complete a full menstrual history as well as past medical history because we have seen particularly that vitamin D, while not necessarily related to recurrent pregnancy loss, can affect fertility. And so regardless of whether or not it has an impact on miscarriage, we still will check it and replete it if it's found to be low. And then with respect to polycystic ovarian syndrome, so that's a constellation of symptoms. Usually patients present with irregular cycles and then have either biochemical, so blood signs of excess testosterone levels, or clinical signs of excess testosterone like acne or excess facial hair. And then plus or minus the classic polycystic ovaries. So the ovaries have lots of follicles and they just have a little bit of trouble ovulating. While we can see an increased risk of miscarriage in patients with polycystic ovarian syndrome, it is not clear whether or not it contributes to recurrent pregnancy loss. And so, really, because there can be some other metabolic conditions that we'll get into in a little bit that can contribute to recurrent miscarriage, really, once we make that diagnosis of PCOS, we then start looking for potential metabolic consequences of that and correct those to hopefully minimize the risk of a miscarriage that way. So this gets me to the metabolic relationship between recurrent pregnancy loss. So here we're focusing on obesity and diabetes. Obesity has been found to lead to an increased risk of miscarriage, but I will say that in studies that have looked at really calorie restricting patients and causing a significant quick loss of weight hasn't always altered that risk. And so really we're focusing more on having an overall healthy lifestyle and making sure that we don't see anything like low or high thyroid or diabetes. Because diabetes can, in and of itself, particularly if it's uncontrolled, also contribute to recurrent miscarriage. However, if diabetes is well controlled, that if you happen to have diabetes, whether it be type 1 or type 2, that in and of itself doesn't put you at risk if it's controlled. It's in the setting of uncontrolled or untreated diabetes. So there are unfortunately still other causes of recurrent pregnancy loss, and what I wanted to focus on next are chromosomal causes of recurrent pregnancy loss. So these can be in the embryo or the fetus. What we can see sometimes are missing or extra chromosomes, and how we can ultimately find this is we are actually able to test pregnancy tissue, and from there can determine whether or not the miscarriage resulted from an abnormal set of chromosomes in the embryo or the fetus. Other times it can be related to what we call parental chromosomal abnormalities. So in the female patient or female-female or female-male couples, we can see that there's an abnormal rearrangement of the chromosomes, which is what we call a translocation. So essentially you can see situations where two completely separate chromosomes end up on top of each other, and then when they try to combine and create an embryo, it becomes an unbalanced situation and unfortunately makes it more likely that that embryo can't continue to develop. And so to check for this, we do a blood screen for patients, and what we're really checking is the karyotype. So for genetically female patients, the chromosomal makeup should be 46XX. For genetically male patients, it should be 46XY. If we see any type of alteration in that, It's usually considered a translocation, and I'll talk a little bit later about how we can treat that. There are also autoimmune causes of recurrent pregnancy loss. The big one is antiphospholipid antibody syndrome. This is a bit of a busy slide, but essentially it's an autoimmune condition where individuals happen to make these antibodies that try to attack certain molecules involved in blood clotting. And so in order to meet the diagnostic criteria for this, while one thing is having a history of more than 2 pregnancy losses, we also will do some blood work looking for these antibodies, and they're called lupus anticoagulant, anticardiolipin antibody, and anti-glycoprotein antibody. I will say, though, it's important to recognize that sometimes these antibodies can be positive, and it may not be related to an autoimmune condition. It could be from a recent viral infection, for example. So we will routinely check again these same antibodies 3 months later if we do find a positive result, to ensure that we're not falsely labeling a patient with antiphospholipid antibody syndrome. Some of the other clinical criteria can be a history of blood clots, or a history of a miscarriage that happens over 10 weeks, or an early delivery, so a preterm birth due to pregnancy-induced high blood pressure. There are also anatomic conditions that can contribute to recurrent pregnancy loss. So there's 2 kind of overarching classes. One, it's called uterine anomalies. So normally it should be like this top picture here. This is the whole uterus. This is one fallopian tube and one ovary. This is the other fallopian tube and the ovary. And then this is the endometrial cavity. This is the inner lining, which is called the endometrium. And then this slightly whiter area is the myometrium, or the muscle layer. And so we can have situations where there are variations of what's considered normal. One can be a uterine septum, where there's this fibrous band that kind of forms in the center of the cavity. That can contribute to miscarriages because if an embryo tries to implant there, there's really no good blood supply for the embryo to keep growing. Yet another condition is called a uterine didelphys, which is, bicornuate uterus, where we do see that there's essentially an indentation at the level of the uterus. So rather than a fibrous band, we just see that there's actually just a severe indentation here of the uterus. And then that also makes it a little bit harder, just because there's a slightly less space for the embryo in terms of development. And then another condition is what we call a unicornuate uterus, where essentially the uterus has almost been cut in half, where we see that it's a more limited space. And usually we still see 2 fallopian tubes and 2 ovaries. However, what's not shown here is that this fallopian tube wouldn't be connected to anything, since we're just kind of seeing half of the uterus there. And so in terms of treatment, or in terms of diagnosis, this is where our ultrasound would come in handy. So in all of our patients who are presenting for consultation, there is an ultrasound involved. And what we're looking for are indentations on the ultrasound that can suggest this, either a septum, a bicornuate uterus, or even a uterine didelphys. And so when that happens, what we ultimately will do is usually a pelvic MRI, because the pelvic MRI will ultimately allow us to distinguish from these different uterine anomalies. There can also be intrauterine lesions that can contribute to recurrent pregnancy loss. These can range from polyps, fibroids, or adhesions. So polyps, which is shown here, these are little overgrowths of the lining of the uterus. They're not cancer, rarely if ever become cancer, but can contribute to miscarriage because they really don't let the uterus or the endometrial lining undergo the changes that it needs to undergo for implantation purposes. Adhesions, which are shown here, are these little fibrous bands of tissue that can form usually after any surgery to the uterus. They, like polyps, make it a little bit harder for the uterus to undergo the changes that it needs to go for proper implantation. And because they don't have a good blood supply, it's kind of like the septum, where if an embryo tries to implant in that area, it doesn't really have much room to grow or anything to really serve as nutrients for it as it's trying to grow. And then the last lesion that I wanted to talk about are fibroids. So fibroids are benign overgrowths of the muscle layer of the uterus, and they can be in a variety of locations. They can be away from the endometrial lining, so we call that an intramural fibroid or a subserosal fibroid, or they can actually be pushing into the endometrial cavity. These are called submucosal fibroids. They can contribute to miscarriage because, again, like the polyps and the adhesions, they make it harder for the uterus to undergo the changes that it needs to undergo for proper implantation. And again, these can be initially somewhat visualized on an ultrasound, which all patients have at their initial consultation. But to really diagnose them more specifically, we would do what's called a saline ultrasound, where we put a little bit of water into the uterus and through a catheter, and at the same time do an ultrasound. And that'll really allow us to delineate between polyps versus adhesions versus fibroids. And again, we'll talk a little bit later in terms of treatment options for this. For these conditions. So the other thing that we'll assess when completing a workup for recurrent pregnancy loss is the role or any potential effect of male-related causes. I know I've talked a lot of the female patient and the things that we're testing for, but I also, in heterosexual couples, wanted to look at male factor infertility. So normally, in heterosexual couples, we will complete a semen analysis. However, the semen analysis, unfortunately, is not sensitive enough for predicting who may be at risk of a recurrent pregnancy loss. And so instead, more recently, what we've started looking at is sperm DNA fragmentation. So this is a test that's really looking at inflammation at the level of the testes. And what we find is that if there's an elevated level of DNA fragmentation, or rather an elevated level of inflammation at the level of the testes or the male reproductive tract, that is also associated with recurrent pregnancy loss and is associated with an increased risk of miscarriage. And we'll talk a little bit more about how to look at that and how we treat that. There also can be, again, genetic causes or chromosomal causes in the male partner, and so we still also recommend a karyotype, so looking at the chromosomes of the male partner as well. I did also want to talk about two, I call them special considerations. There's something called luteal phase defect. So this is something that up until now, it still has been challenging to develop a good diagnostic test, or rather screening test for this. And that's because luteal phase defect, what it implies is that there isn't enough progesterone around to support a pregnancy. So there are two big hormones that are being released and affecting the endometrium in preparation for implantation. One is estrogen. That increases as an egg is growing or as a follicle is growing. And the second one is progesterone, which is released after the egg has been ovulated. There are some situations where either there isn't enough progesterone being released from the ovulated egg, or there isn't enough of a time frame for exposure of that progesterone. And so that's what we've termed luteal phase defect. The problem is there isn't really a good test for that. So people have tried dating, we call it dating the endometrium, so doing an endometrial biopsy to see if the timing of where a person is with respect to ovulation matches where their uterus is. That unfortunately hasn't been useful in diagnosing. We also have looked at checking progesterone levels in the bloodstream. That's also been challenging because progesterone release is pulsatile, and so depending on when we check it, it may look falsely low or falsely normal. And so instead, what a lot of us do and what I do is I really look more at how long is the luteal phase. So there's two phases of the cycle. One way to describe it is when estrogen's the dominant component and when progesterone comes on board. The other way to describe it is the follicular phase and the luteal phase. So follicular phase is when the egg is growing, when estrogen's increasing. The luteal phase is after the egg has been ovulated and progesterone's increasing. And so what we're looking at is, although a given woman's cycle can vary anywhere from 21 to 35 days, what should be relatively constant is the luteal phase, which is around 12 days on average or normally. And so usually what I'll ask my patients is, when they're tracking their cycles from when they ovulate to when they have their next period, how many days is that? And if it's less than 12 days, these are usually patients that I'll treat with supplemental progesterone. There's another condition known as chronic endometritis. So it's an infectious etiology. It is not a sexually transmitted disease. I just want to make that perfectly clear. It's really something where there can be a prior infection, not STD related, that can contribute to some inflammation in the uterus. Sometimes people are completely asymptomatic, sometimes they have irregular bleeding. The way that we diagnose this is by endometrial biopsy. And so this is something that we can also treat and look for. What's been challenging is that it's not exactly clear how much this contributes to recurrent pregnancy loss, but is something that we can talk about with you in more detail during your consultation. So now that we've gone over the various causes of recurrent pregnancy loss, the next thing that I wanted to go over are treatment options based off of a diagnosis or based off of risk factors that a given patient may have. So the first is going back to thyroid disease. So in individuals who have a history of a high TSH, meaning low thyroid hormone, we simply replace thyroid hormone, and we replace that with levothyroxine, Synthroid, so a synthetic version of the thyroid hormone. And then initially we'll monitor those thyroid levels monthly until it's gotten to a normal level. And then at that point, hopefully you're pregnant, and we'd recommend that your OBGYN or your OBGYN will check it every trimester of pregnancy. For hyperthyroidism, these patients we usually actually refer to a medical endocrinologist just because the treatment does vary based off of the severity of the condition, the cause, and how patients initially present. And the treatment can range from medication to radioactive iodine to surgical management. What we do say, however, is that until the hyperthyroidism is controlled, we actually would recommend holding off on conceiving until that time point. If we find that there's an elevated prolactin level, which again is a blood test, we actually would first repeat it because prolactin can be elevated for a variety of reasons: exercise, hot showers, recently eating. So we always have this lab checked when individuals are waking up in the morning, not having anything to eat or drink, not having exercised or taken a hot shower recently. And if it's elevated on 2 separate occasions, actually the next step is ordering imaging of the brain. It's called a pituitary magnetic resonance imaging. And that's because sometimes the prolactin is actually elevated because there can be a tumor in the brain. Almost always benign, meaning non-cancerous, almost always quite small, and almost never requires surgical treatment. But if we did find that, in addition to treatment, we'd also want to yearly monitor that tumor to make sure it's not growing. And so the treatment here, again, no surgery needed. We actually do medical therapy with medications called either cabergoline or bromocriptine. They essentially lower prolactin levels to help normalize menstrual cycles and to help normalize the changes that need to happen for proper implantation. We normally repeat the prolactin level monthly until it's normalized. And then once it's normalized, we can let patients who are trying on their own, they can start trying to conceive again. And then we normally stop this medication once patients are pregnant. Cabergoline and bromocriptine technically act through the exact same mechanism of action. It's just that bromocriptine tends to have more side effects because it's not as specific as cabergoline for targeting prolactin production. So what about in patients who ultimately meet the diagnosis of antiphospholipid antibody syndrome? So again, antiphospholipid antibody syndrome is essentially a condition where an individual makes antibodies that try to target normal blood products or normal blood molecules. And how that contributes to miscarriage is because it essentially causes a lot of inflammation at the level of the uterus and also at the level of the placenta. And so the treatment then really focuses on blocking inflammation and blocking these antibodies effects. And so before pregnancy, we'd recommend starting a baby aspirin, so an 81 milligram dose of aspirin. And then once pregnant, it's an anticoagulant, it's called heparin. We're taking advantage of the non-clotting component of it, but really it's also the anti-inflammatory effects of heparin as well. And because patients with antiphospholipid antibody syndrome are more predisposed to having a blood clot because of these antibodies. Normally, after pregnancy, it's recommended that you continue the anticoagulation or the heparin for about 6 weeks postpartum. And then we normally recommend that if this diagnosis is made, we avoid any types of medications that have estrogen in them to help further minimize any risk of a blood clot forming. If we find that there's a chromosomal disorder, so for example, if we are able to test the pregnancy tissue and see that there's an abnormal set of chromosomes, then we'll talk a little bit more about considering in vitro fertilization. So that's where patients receive, or female patients receive, injectable hormones. We get lots of eggs to grow at once. We ultimately retrieve those eggs, combine them with sperm, and watch them develop into embryos. The reason why we may want to consider IVF is because with IVF, once we have embryos, we can actually test the chromosomes of those embryos before actually considering putting that embryo back inside you. And the test it's called PGTA. It's about 95% accurate. So when we get a result that says the chromosomes of this embryo are normal, it's highly likely that that embryo is normal. And so we'd minimize the risk of a miscarriage from abnormal chromosomes in an embryo. Now, if it turns out that there's an abnormal set of chromosomes in the patients, then we first refer you to a genetic counselor to talk a little bit more. It can be a variety of different rearrangements of the chromosomes, talk a little bit more about what your specific rearrangement means for you. And then ultimately, we also again recommend in vitro fertilization because in addition to checking, is it the right set of chromosomes, yes or no, we can also look to see if there's any rearrangement of those chromosomes as well. And so we can ultimately select the embryo that does not have that rearrangement or that doesn't have an unbalanced set of that rearrangement. If we find that there's a uterine anomaly, for example, like a uterine septum, we do recommend surgical management. And that's thankfully essentially curative because we're removing that fibrous band of tissue. And so we essentially we prevent the embryo from having to implant on a fibrous band because it's now been removed. And so now normalize the likelihood of getting pregnant. This surgery, though, does take some time for the uterus to heal. So it's a hysteroscopic procedure where you're completely anesthetized. There's a little camera, we called it a scope, that goes through the cervix into the uterus, and then we essentially just shave off or cut out that septum. But we normally need to give the uterus about 2 to 3 months to heal before trying to conceive. Unfortunately, the remaining uterine anomalies that we talked about, so a uterine didelphys, which is where essentially the two cavities of the uterus never met, and so it's almost like you have two uteri. The bicornuate uterus, which is where there's that sharp indentation, and then also the unicornuate uterus. Unfortunately, there is not treatment for those. Surgeries have been done in the past, at least with respect to the bicornuate and the uterine didelphys, to try and essentially bring the uterus back to its normal shape. But those unfortunately did not actually help in terms of pregnancy or minimizing risk of miscarriage or any other pregnancy-related complications. So now we say that if you do have that condition, in addition to talking to you about recurrent miscarriage risk, we will also discuss potential pregnancy complications. And if and when pregnancy does happen, we recommend that you are followed by a high-risk OBGYN or a maternal fetal medicine doctor so that they can monitor you closely and ensure that the baby's growing appropriately and that you're not at risk of any preterm birth. The other option, of course, and I put this in here just so that you know that it's an option, it's not something that you have to do, but some patients would consider gestational surrogacy, so creating embryos and having someone else carry the pregnancy. Again, not required, just wanted to let you know that that's something that is an option. So then we get to the intrauterine lesions. If you recall, we talked about polyps, which are overgrowths of the lining of the uterus, fibroids, which are overgrowths of the muscle layer of the uterus, and then adhesions. With polyps, the data has actually been a bit conflicting in terms of, do all polyps need to be removed? Is it just certain size polyps that need to be removed? Technically, according to the available studies, it's polyps that are over 1.5 centimeters that should always be removed. That being said, I actually, again, before moving back to California, was conducting a lot of research on the uterus. I really do feel that all polyps should be removed regardless of the size because they're not supposed to be there, and they do, again, make it harder for the uterus to undergo the changes that it needs to undergo for proper implantation. But again, this is something that would be individualized based off of your particular situation, and so it's something that we could talk in more detail in a consultation as well. With respect to fibroids, the ones that we say should definitely be removed are the ones that are submucosal. So those are the ones that are actually pushing into the lining of the uterus. And that's because, again, doesn't allow the uterus to undergo all the or the lining of the uterus to undergo all the changes it needs to undergo for proper implantation. The other fibroids, the ones that are essentially not within the endometrial cavity, those, there has never been a cause and effect between those and recurrent pregnancy loss. That being said, again, everything is individualized. We don't generalize for a given patient. Of course, I'm giving you all of this data in some ways in a general form, but once it comes to your specific consultation, we go through your specific history and then weigh out the benefits and risks of removing some of these other fibroids. And then adhesions, we also recommend removing. Usually these will result from a prior D&C, so any type of scraping of the uterus that may have happened or a prior infection. Again, the concern is that these adhesions aren't allowing the uterus to undergo the changes that it needs to undergo for proper implantation, or the embryo is trying to implant on that adhesion, which doesn't have a good blood supply or really any blood supply to it. And then again, all of these surgeries are hysteroscopic, meaning all minimally invasive, all with a little camera going into the uterus and either cutting out or shaving off any of these lesions. And again, recommending about 2 to 3 months for all of these in terms of allowing for appropriate healing of the uterus before trying to conceive. So the other two conditions that I wanted to talk about, I know I kind of got into it a little bit already, were a luteal phase defect. Again, conflicting data with respect to the effective treatment just because of a lack of a validated test for assessing for luteal phase defect. I usually go based off of a given patient's history and how long their luteal phase is. And so in general, I would recommend supplemental progesterone because, again, what we're really looking at with luteal phase defect is that there isn't enough progesterone exposure for proper implantation. And so we can supplement that in a vaginal tablet. And usually we recommend supplementing it starting it a few days after ovulation. Chronic endometritis, also conflicting data, just because, again, there's no valid test. I know I talked about performing an endometrial biopsy, but even among pathologists who are the ones who are actually looking under the microscope at that biopsy result, there is not a clear guideline for what constitutes chronic endometritis versus a potential normal variant. And so normally what I would say is that we can do an endometrial biopsy if it does look like there's chronic endometritis. Although no clear data that antibiotics are effective, I normally would treat with a course of antibiotics prior to attempting pregnancy to clear out that infection, clear out that inflammation, hopefully make it easier for a subsequent pregnancy to implant. And then the other part that is also a little bit conflicting with respect to data is how we treat male factor-related causes of recurrent pregnancy loss, specifically when we're looking at elevated DNA fragmentation. So in general, I will refer my male patients to a urologist if we find that there's an elevated level of DNA fragmentation. And usually what we're recommending, although again, not 100% clear on how much this improves or rather minimizes the risk of a miscarriage, but we usually will consider moving on directly to IVF because, again, in addition to being able to test embryos, we can also alter how we inseminate the eggs. And so we can do something called intracytoplasmic sperm injection, where we essentially select out the best looking sperm. Our embryologists do this under a microscope and then directly inject the egg with the sperm. Some other options, depending on whether or not that's already been done and has unfortunately not been successful, are to actually consider testicular sperm aspiration. So aspirating some of the sperm directly from the testes, because the thinking is maybe there's less inflammation before the sperm starts traveling through the male reproductive tract, and seeing if that combined with IVF or ICSI would help minimize the risk of a subsequent miscarriage. And again, this is something that we talk about on an individualized basis, just given the fact that the data isn't completely clear yet on how much of a benefit this is to complete this test and ultimately change treatment as a result of it. And so the last couple of things that I wanted to talk about are how do we ultimately treat recurrent pregnancy loss, especially when we may not always find a diagnosis. So I know I went through the various causes and the things we'll check for. Sometimes we don't actually find a problem in the sense of thyroid is normal, prolactin's normal, uterus is normal, there's no evidence of chronic endometritis, there's no chromosomal issues. What I do want to reassure you of is that the likelihood of having a baby and not having another miscarriage is very, very high. I actually included this figure here. I know it's a little bit busy, but the thing to take away is not that I would wish on anyone any miscarriages, but if, for example, somebody had 6 miscarriages, the likelihood of getting pregnant is still over 50%. So there's still a very, very high likelihood of getting pregnant, even if you unfortunately are diagnosed with recurrent pregnancy loss. And so that's the key thing to take away. We, of course, will evaluate everything. And at the end of the day, and through some additional treatments that I want to talk about next, there's still a very high likelihood of pregnancy. And so what I wanted to talk about here are, again, let's say everything comes back normal. What is it that we can do to still help optimize your likelihood of getting pregnant, staying pregnant, and having a baby? So one of the things that I usually recommend for all of my patients is aspirin, 81 milligrams. I know we talked about that with respect to antiphospholipid antibody syndrome, but there actually was a study in 2021 that looked at in patients with a history of recurrent pregnancy loss, what happens if you have them take baby aspirin every day, which is probably minimizing inflammation. And in the patients, or in the subjects rather, who took a baby aspirin at least 4 to 5 days out of the week, there was actually a lower likelihood of miscarriage. Initially, actually, the trial reported no difference, but when they went back and analyzed it and specifically looked at subjects who took it almost every day, there actually was a decreased risk of miscarriage. So now, in patients who maybe don't necessarily want to do IVF, I will still, and want to continue trying on their own, I still do recommend starting a baby aspirin before you next start trying again. Progesterone's another interesting one. There is also various reviews in the literature. There are various reviews of the literature looking at how progesterone may or may not help. I know we talked about it with respect to luteal phase defect, but actually even in patients who I don't feel have luteal phase defect, I'm usually still recommending vaginal progesterone. The studies have been conflicting because it hasn't consistently, not every single study starts progesterone at the same time. So some will start it once there's a positive pregnancy test. Some will start it once they see a heartbeat. Others will start it only if there's bleeding in early pregnancy. And then others, like me, will actually start it in the luteal phase. And my thinking for that is if progesterone normally starts rising in the luteal phase after ovulation, then the time to really supplement, or rather augment, your own progesterone is at that same time. And so for individuals who are using, for example, ovulation predictor kits, I usually say start vaginal progesterone 4 days after that ovulation predictor kit has turned positive. There's really no harm to progesterone or extra progesterone. The one thing to keep in mind, though, is that it can keep you from getting a period even if you're not pregnant. And so it is still important to take that pregnancy test about 2.5 weeks after ovulation, because if you're not pregnant, then we have you stop the progesterone so you can get a period and then start trying again. Other things are more lifestyle modifications, so limiting caffeine intake. Anything over 300 milligrams has been associated with recurrent pregnancy loss, so we recommend no more than 200 milligrams. Avoiding alcohol, avoiding smoking, and then just optimizing general health. Again, I know we talked a little bit about obesity and risk of miscarriage. I'm in no way saying going on a crash diet. I know that it can be really challenging to lose weight. Really, it's more healthy mom, healthy baby. So really just focusing on a healthy lifestyle, not so much drastic losses in weight. And then in patients who are diabetic or pre-diabetics, monitoring that blood sugar, again, adjusting your diet to help lower that risk of diabetes or uncontrolled diabetes. So just to summarize, there are a variety of causes of recurrent pregnancy loss, both hormonal, metabolic, genetic, anatomic, and then also lifestyle factors. Sometimes we don't find a reason, but that being said, there's still a very high likelihood of getting pregnant. And my job, and I know I speak for all of the doctors here at SDFC, is to take your particular history and individualize care for you to optimize the likelihood of success. And with that, I just wanted to end with this, which is that there is no proof that stress, anxiety, mild depression, meds you did or didn't take cause recurrent pregnancy loss. But we do know that emotionally, it can take such a toll on you. This is not an easy thing to go through, and we truly are here to help guide you along the way, not just medically speaking, but also with respect to psychological support and counseling. We are here for you, and our goal is your goal, which is to ultimately have you go home with your little one. And so with that, I'll actually stop sharing. I'll see if there are any questions that we might have. The questions you can also put into the chat. Oh, this is a great question. So the question is, for patients who are pre-diabetic who are taking metformin, is it okay to continue that during pregnancy? So that actually recently underwent a change. I'd say in the past year, we used to have patients continue it during pregnancy. Now the high-risk OBGYNs actually recommend stopping it in pregnancy, but of course still having regular monitoring, because we know that patients who are pre-diabetic are still at risk of ultimately having diabetes in pregnancy. And so during the first trimester, you'll have that diabetes screen, so that blood sugar drink or the sugar drink, and then checking your blood sugar levels, so that we'll still be able to identify patients and then switch medication to something that is now more considered mainstream for patients who are pregnant. Mm. Oh, there's another question. So one of the questions was looking at the role of thromboembolic disease and risk of miscarriage. So we call them inherited thrombophilias. So there are some genetic causes, for example, factor V Leiden, prothrombin mutation, that contribute to putting patients or women at an increased risk of blood clots. In the past, that was actually part of the recurrent pregnancy loss workup. However, ultimately, it has been found that being a carrier, even being fully affected by one of those conditions, does not increase your risk of an early miscarriage. And so we normally don't check for that anymore, actually. Again, if there's a history, a strong family history of blood clots, or if you yourself have a history of a blood clot and that hasn't been worked up before, absolutely, we would check for those conditions, but it's just not a routine test for anyone who doesn't have risk factors for that. Yeah, so the other question is, in patients who have longer cycles and have struggled with miscarriage, what would be the next step in evaluation? So one of the things, so I would say the big thing is completing a more thorough hormonal examination. So not just checking the fertility labs, but also checking for something like polycystic ovary syndrome, and also some of the other conditions that we talked about. So checking thyroid hormone, checking prolactin, and then seeing whether or not either prolactin's elevated, thyroid's up or down, or whether or not patients meet the criteria for PCOS. If it's PCOS, well, first of all, if it's thyroid disease or prolactin, those we can manage with medication. Usually it takes about a month for the thyroid or the prolactin to normalize, and then it would be okay to try again, of course, staying on that thyroid medication or the prolactin medication. If those are normal and you actually meet the diagnostic criteria for PCOS, the one thing that I do differently for these patients is I actually supplement them with progesterone as well, because progesterone is actually also an anti-inflammatory agent. And patients with PCOS, it has been found that there may be a little bit more inflammation at the level of the uterus. So these are patients that I would actually also put on supplemental progesterone. And then if the period, if actually we also find out that prolactin's normal, thyroid's normal, but the periods are still a little bit prolonged, actually considering some agents, some ovulation induction agents to help ensure that we're getting a good follicle slash egg to grow, and more specifically timing ovulation with what we call a trigger shot. And then in addition to that, supplementing progesterone. Another question. Okay, the next question is, what if everything comes back normal? So if everything comes back normal, then I would say, first of all, I know it's really hard. In some ways, you almost want to find something wrong because then you can treat it. But it still is reassuring that there aren't any abnormalities, although that doesn't make it any easier with respect to miscarriages. So I would say the next step would be, one, thinking about maternal age. As women, we do unfortunately have a time frame of when we have eggs and when we have good quality eggs. And unfortunately, as we get to be in our late 30s, the quality of our eggs goes down. And quality is really referring to the ability of the egg to divide properly, to have the right set of chromosomes. So I don't know the age of this particular patient, but if it's someone in their late 30s, early 40s, one thing to consider is going to in vitro fertilization, just because we have the ability to test the embryos. However, if it's a younger patient, or if IVF is something that you're not interested in or financially may not be possible, then I would still recommend baby aspirin before the next attempt at pregnancy, and adding on vaginal progesterone after ovulation. So if you're doing ovulation predictor kits, essentially 4 days after that, starting vaginal progesterone. The one that I like is Prometrium. So it's a 1 tablet, 200 milligrams in the evening, vaginal tablet. So then the next question is looking at patients who are taking already progesterone supplementation, metformin, Synthroid, and a baby aspirin. I think one of the questions is age, and then, or my question, sorry, is age. And then the other thing is endometriosis. So actually, that's my other area of interest, and my specialty is endometriosis. Okay, younger. So in that situation, surgery actually for endometriosis is plus minus. Usually we can diagnose now clinically. Surgery in and of itself really has been found to shorten the time to pregnancy. It hasn't necessarily impacted pregnancy loss risk, in the sense of, the biggest thing with endometriosis is, again, inflammation, and there are adequate levels of progesterone in women with endometriosis, but the body doesn't respond appropriately to it. So the endometriosis continues to grow, and the lining of the uterus also gets resistant to progesterone. And remember, progesterone is really important for implantation. So really, the progesterone should be helpful if pain is a big component of the endometriosis. Some people are completely asymptomatic, but if pain's a big component, then yes, because it can be harder to continue undergoing cycles after cycle of trying to conceive and having that estrogen lead to more endometriosis growth. In the absence of pain, I don't think a surgery is necessarily indicated or is necessarily going to change that risk. One other option to consider, actually, you won't find this in a textbook or online, but just thinking about the important role of progesterone, particularly in patients with endo where there can be progesterone resistance, is increasing the dose of vaginal progesterone. So going for, if you're already taking 200 milligrams, increasing it to 400 milligrams, so 2 tablets. So 1 in the morning, 1 in the evening. Can also consider progesterone shots, because you get a higher level of progesterone that way. Or again, even thinking about IVF. IVF has been one of the best treatment options for patients with endometriosis, because there's a lot of different components of how endometriosis can contribute to both infertility as well as miscarriage risk. There's a lot of inflammation in endo. With IVF, you take those eggs out of that inflammatory environment, and in the lab, fertilize them. And then the next step with IVF is that we give you tons of progesterone, because we do what's called a medicated embryo transfer cycle, where we give you essentially always progesterone shots to help improve the likelihood of pregnancy. The other thing that we're doing, and it's actually being studied right now in terms of how this impacts pregnancy outcomes, is actually treating the endo so we can preemptively treat you as endo medically. The medication's called Orilissa for 2 months. And what that does is essentially knock out all the inflammation. And so theoretically, letting the uterus start to respond normally again to progesterone. So that's another option as well. More questions? Okay. I think those are all the questions. Thank you all so much for taking time out of your evening for participating in this webinar. Please don't hesitate to reach out should you have any additional questions or if you want to make an appointment. And I hope everyone has a great holiday.